Multiple myeloma. Um, Multiple myeloma. So this represents a malignant proliferation of plasma cells derived from a single clone. So the plasma cells proliferate, and these plasma cells are derived from a single clone. The tumor and the products of the tumor and the host response. The tumor, its products, and the host response to it result in a number of organ dysfunctions and symptoms, including bone pain or fracture, renal failure, susceptibility to infection, anemia, hypercalcemia, occasionally clotting abnormalities, neurologic symptoms, and manifestations of hyperviscosity. So, what is multiple myeloma? So, this is a malignant proliferation of plasma cells. So, these plasma cells are derived from a single clone. The tumor, the products of the tumor and the host response to it. So, this result in a number of organ dysfunctions and symptoms, including bone pain or fracture, renal failure, susceptibility to infections, anemia, hypercalcemia, occasionally clotting abnormalities, neurologic symptoms, and manifestations of hyperviscosity. Etiology. The cause of myeloma is not known. So, this myeloma occurred with increased frequency in those exposed to the radiation of nuclear warheads in World War II after a 20-year latency. So, people who were exposed to radiation of this nuclear warheads in World War II. So, after a 20-year latency, they developed this myeloma. So, myeloma, this has been seen more commonly than expected among farmers, woodworkers, leather workers, and those exposed to petroleum products. So, this myeloma, so this has been seen more commonly than expected among farmers, woodworkers, leather workers, and those exposed to petroleum products. Farmers, woodworkers, leather workers, and to petroleum products. A variety of recurrent chromosomal alterations have been found in patients with myeloma. So, what are the different chromosomal alterations in patients with myeloma? Hyperdiploidy, trisomies involving one or more of chromosomes. So, trisomies involving one or more of chromosomes 3, 5, 7, 9, 11, 15, 19, 21. So, this is observed in half of the patients. So, in half of the patients, trisomies involving one or more of the chromosomes 3, 5, 7, 9, 11, 15, 19, 21, and the other have translocations involving the 14q32 and chromosome with variable partners, including, see, the other half have translocations involving the 14q32 chromosome with variable partners, including the T1114, T414, and T1416. 14 is there. T1114, T414, and T1416. So, other frequent abnormalities. So, what are the other frequent abnormalities? So, the other frequent abnormalities include 13q14 deletion, 1q amplification or 1p deletion, and 17p 13 deletion. So, what are the other frequent abnormalities? 13q14, 1q amplification or 1p deletion, and 17p 13 deletion. Other half have the translocations 14q32 chromosome with variable partners, including translocation 11, 14, 414, and 1416. So, evidence is strong that errors in switch recombination, the genetic mechanism to change antibody heavy chain isotype, so this participates in the early transformation process. So, evidence is strong that errors in the errors in the switch recombination. So it is the genetic mechanism to change the antibody heavy chain isotype. So this participates in the early transformation process. However, no single common molecular pathogenetic pathway has yet emerged, and genome sequencing studies have failed to identify any recurrent mutation with frequency greater than 20%. So genome sequencing studies were done, but these genome sequencing studies, they fail to identify any recurrent mutation with frequency greater than 20%. NRAS, KRAS and BRAF, so these mutations are most common and combined, so this occurs in greater than 40% of the patients. So what are the mutations? NRAS, KRAS and BRAF mutations are most common and combined, so they occur in greater than 40% of the patients. Evidence of complex clusters of subclonal variants is present in diagnosis, and additional mutations are acquired over time, indicative of genomic evolution that may drive indicative of genomic evolution that may drive disease progression. Interleukin 6 may play a role in driving myeloma cell proliferation. So what is the interleukin 6 which play a role in driving myeloma cell proliferation? Which is interleukin? So this is interleukin 6. And it remains difficult to distinguish benign from malignant plasma cells based on morphological criteria in all but a few cases. So if we take this figure, so the multiple myeloma marrow, the cells bear a characteristic morphological features of plasma cells. So these plasma cells are round or oval cells. Round or oval cells with the eccentric nucleus composed of coarsely clumped chromatin. The chromatin is coarsely clumped, a densely basophilic cytoplasm. So the cytoplasm is densely basophilic and a perinuclear clear zone containing the Golgi apparatus, and there is a perinuclear clear zone containing the Golgi apparatus. Binucleate and multinucleate malignant plasma cells can be seen. Binucleate and multinucleate malignant plasma cells can be seen. Myeloma increases in incidence with age. The median age at diagnosis is 69 years. It is uncommon under age 40. Males are more commonly affected than